So 15 to 20% of the unhappy patients following total knee arthroplasty are based on our errors in case selection. So we miss which patient needs which procedure. Is it anteromedial osteoarthritis, which demands UKA, or is it a two-level osteotomy, distal femoral as well as high tibial osteotomy, or only the high tibial osteotomy, or is it a total knee replacement, or some patients we have done like one side TKR and on one side osteotomy as per the patient or the deformity dependent. So the basic concepts of UKA, as we have been seeing, it's no soft tissue release, but little bit soft tissue whenever it is needed, and we always try to do under correction, and there should be no overstuffing of the other compartment. And we target a neutral alignment rather than going into a valgus alignment, and there is a big no-no for the tibial malalignment and eccentric tracking and edge loading. So essential rules: read the patient, case selection is essential, ready to learn and adopt new techniques, respect the learning curve and regular interval, so that keep doing the cases so that the margin of error is less. At the end of the day, the surgical skill and the knowledge is more essential than the implants, instrumentations and the techniques. The CORI helps in achieving a limb alignment within 1-2 degree of the plan with more accurate restoration of the joint line compared to the conventional method. And this is one of our study where we took 100 cases, which we did from 2018 to 20 with a minimum 3-year follow-up. And in group A, using the CORI, the mean error of the joint line was like 1.6, and the less than 2 mm was like 64%. While we have been using conventional method, where we found it was like 2.47 joint line deviation, with less than 2% is like 18%. So the femoral component distal positioning was higher in the conventional method when compared to the robotic. And as we know, distalization of the femoral component is associated with the early wear and a high failure rate. And another one study where we took 100 cases with 3-year follow-up period, and here the posterior tibial slope, pre-operative it was like 9.1 on the average of 100 patients, and post-operatively we were able to restore it to 4.3 plus or minus 2 deviation. And as a target for ourselves, when we targeted like 5 degree, at the end of the surgery we were able to achieve 4.3 within 2.1. That is the margin of replication or reproduction of what we have planned was like good with the robotics. And another one is like HKA, and static HKA, as we measure with the pre-op X-ray and post-op X-ray, the pre-op was 8.4 and the post-op was like 4%. Oxford 4 obviously improved from 25 to 44. And the good thing is about this is dynamic, where we are able to do the dynamic HK pre-operatively, and we set a target for ourselves and how much we achieve the dynamic HK on table at the end of the surgery, and we are able to reproduce it. And this is one of the paper like where to have a good patient satisfaction, we should leave a minimum amount of gap in the medial compartment so that the lateral compartment is not overstuffed. And this we have been able to reproduce more with the help of CORI rather than the conventional method. So this we presented in the ISTA last year, and so all the patients go through the basic pre-op workup, and radiological fitness is more essential than before getting into the surgery. And most of these cases are like mild to moderate deformities and rarely very posterior osteophyte, where CT scan is going to score. And here real-time registration, so here the surgeon does, so it gives a good registration, and there is no need for any CT and extra radiation. So the tidal mark, sometimes in a CT there can be error as different people mark around, but on table you decide the tide mark, which is the junction between the articulating and the non-articulating portion, and that also helps in sizing of the proper implant. So we give importance for the dynamic tide mark. Second is the stress view, like with the dynamic ROM and the stress, whether with the valgus and the valgus, everything is taken account, which is not available with the image-based system. And the sizing, you will be like doing the sizing when you are seeing the closed structures of ACL and other meniscal achievements, which adds value. And here you can play around on table, like if it is the size is shown 2, you can even change into the size 3, and you can get the score. And joint line restoration, like we are talking about like millimeter, like 1 millimeter, 2 millimeter, how much gap we need to give. And edge loading, we are almost like defining a safe zone where the edge loading should be, where the articulation should be in a tibia, whether it is in the medial most or in the central or the lateral most. In the tibia, we target it in the junction between the medial most and the center, and in the femur, depending upon, because a lot of variations in the distal femoral morphology because of the loading. So at the end of the day, we give importance for the femoral joint line as well as the tibial joint line. And this is this X-ray shows the valgus, tibia in little bit varus, but the overall scanogram shows the good picture. The another one example where our routine patients of this age group 48, and here again the single X-ray, the small X-ray shows it is in bit varus, but the static X-ray shows correct equilibrium. And as with the using the robotics, our age has been like improved. Like we do like for 80-year-old and with a single stage, and bilateral patients in a single stage more than 75 years, and the patients are like happy. And whenever like such deformities like hyperextension, initially we used to jump and do total knee arthroplasty, and this patient was a particular blind and we wanted to have a good proprioception. We did a diagnostic scopy, MRI, and then proceeded with, and we were able to restore the joint line and stable joint, and the patient is going good. So efficiency is like, it's been radiation free, it's a simple, compact, and it's a handy, and it's a constant evaluation in the technology, as we can see from Navio to CORI, and interpersonal variation is very less, and it's a semi-haptic, which where both robotics and humans go to hand to hand. Again, it's a quick registration, and the yearly discharge and pain score is like a valid point. So take home message: avoid overcorrection, undercorrect, varus angulation of tibial slope, and the posterior implant, avoid slope of more than 7 degrees. Thanks.